Welcome to Chapter 1, Introduction to Emergency Medical Care. This chapter does a great job of introducing you to the origins of EMS, giving you a better idea of where we come from and why we do the things that we do. So as with all the PowerPoint presentations, there'll be a list of multimedia and objectives that you can review at the beginning of the chapter. Remember that if you'd like to go back and take a look at any of that stuff specifically, in addition to these presentations, you can access the PDF of all the PowerPoints through Canvas. So beginning with the Emergency Medical Services System, or EMS System, gives you a basic idea of what we do and ultimately where our origins come from. So dating all the way back to the late 1700s and early 1800s, France, under the direction of Napoleon, was engaged in a series of European battles. And it was at that time that they began to understand the value of battlefield care. The cost of losing soldiers and not being able to treat them and get them back into the battle was not efficient. And while we would like to assume that all of our battlefield care origins came from compassion and the desire to want to treat people and help people, that's not necessarily the case. Even in the instance of war, we have to look at the cost and cost efficiency. So Napoleon and his generals began to implement what was one of the first field hospitals. Those field hospitals sat about 3 miles behind the front lines and provided that general first aid care. The problem was getting the injured soldiers from that battlefield line the 3 miles back to the field hospital. So during that time, they began to realize the efficiency of the horse-drawn carts, and they began to evacuate those injured soldiers to the field hospital. The downside, of course, that's still a 3 mile transport, and by a horse-drawn carriage, that takes quite some time. So during the Civil War, the same thing was implemented. However, we began to provide some basic first aid care right there at the front lines. As people would go down, they would receive some limited aid, not necessarily from anybody trained in first aid, but they would at least try to stop some of the bleeding if possible. These forward aid stations provided the early intervention for injuries until they can get back to the field hospitals. Moving forward to World War I, 2 first aid personnel were assigned to each company. Their role, again, was to stop the bleeding, apply some basic splints, and they were also concerned about tetanus. So they'd be providing some basic vaccines at the time to try to prevent against the tetanus from building up. If you remember, during the Civil War and even in World War I, we started losing more people to infection and illness than we did the actual injury themselves. Korea and Vietnam was unique. We started using helicopters at that point, and the helicopters did a handful of things. They obviously were enabled us to access areas that were otherwise difficult to access by ground, but more importantly, they really sped up the speed at which we could get people to those field hospitals. So people were able to get more comprehensive, more advanced levels of care earlier on following the injuries. In addition to that, the same Army medics, Navy corpsmen were embedded within the units there. Think today, how does military application of trauma care translate to civilian EMS? And it's actually pretty neat, because when you think about it, the use of tourniquets and hemostatic agents in civilian EMS was really a foreign concept up until just a few years ago. Everybody seemed to think that if we applied a tourniquet to somebody, they were going to lose their arm or lose their leg. And it was a scary thing. When I started in EMS, tourniquets were not taught. It was not within our scope of practice. It wasn't until the Iraq and Afghanistan theaters, beginning in 2001, 2002, 2003, that we began to realize the value of hemorrhage control. Even then, in the EMS application of trauma care, they were teaching ABCs, airway, breathing, circulation. And while that's still very, very important, we began to understand that hemorrhage control was just as important as monitoring that airway and breathing. And ultimately, if we maintained a good patent airway, but the patient had no circulating blood volume, it really did us no good. So through those studies and those trials, we realized that we need to be focusing more on hemorrhage control. And especially in today's day and age where we're looking at active shooter incidents on a pretty consistent basis. Hemorrhage control, active shooter bags, those types of things are a pretty standard tool that are provided by the EMS agencies now. EMS system protocols reflect hemorrhage control needs, and things like hemostatic agents and tourniquets are readily available at our disposal. So a couple pictures of different ambulances throughout the years. You'll notice here the term dust off. Dust off is actually because of the dry environment that these helicopters were working with. Every time they take off, there was a substantial amount of dust. So the term dust off meant that they were actually taking off and being transported to the next field hospital. So non-military ambulance services. There's a handful of different cities that began to implement various types of ambulance services, if you will. But generally speaking, ironically enough, a lot of ambulance services up until probably the 1950s or so were provided by the local funeral homes. Now, if there wasn't a slight conflict of interest there, I don't know what is. But even today, we still see a lot of ambulance companies provided either through private agencies, but especially hospital-based. If you go out even into Western Illinois, you'll see a lot of ambulance companies are based. They respond from hospitals and provide services throughout the region that they cover. The problem now was that there weren't much in the way of standards. It was a matter of drive to the scene, throw them in the back of the ambulance, drive to the hospital, and all the treatment is done at the hospital. Very little, if any, treatment was actually done on scene or in the back of the ambulance. So the modern day EMS that we're used to now is actually very, very new. We didn't start to see a lot of this stuff until the 1950s. As we began to improve our ability to transport patients, we began to realize, okay, it would sure be great if we could provide some level of care in the back of those ambulances. And with that, obviously, we needed some regulations. Who's going to govern what's done, how it's done, where it's done, etc. So in 1966, the Department of Transportation was charged with developing EMS standards. And just of note on this slide, you'll notice that it's circled. There's a big red arrow, and it says it's circled because it's important. You should probably just completely disregard that because I'm sure it's not important at all. That's a joke if you didn't get it. There's a few things like this on the PowerPoint slides. While all the information is important, I've taken the time to call out a few different facts, something that you might see pop up, I don't know, maybe on a quiz or an exam or something like that. So in 1966, the Department of Transportation was charged with developing EMS standards. Within them, they kind of looked at this and said, okay, what the heck do we do with this? Why is it that the Department of Transportation is charged with this task? And think about that. Why would the DOT be charged with the task of EMS regulations? Well, ultimately, EMS is performed in the back of an ambulance, and what does an ambulance drive on? The roads. So the Department of Transportation was just kind of the unlucky one to get charged with this. Quickly realizing that they really didn't know what they were doing, and it wasn't within their realm of responsibility, they formed a department within the DOT. That department is called the National Highway Traffic Safety Administration, NHTSA, and that's still in full force today. 1970, NREMT was formed. So again, we start to see a lot more progress in way of regulations, trying to make sure that everything is done consistently and that there are some standards that are blanketly applied throughout the United States. 1973, National Emergency Medical Services System Act passed by Congress. That act provided a lot of guidance as far as what would be acceptable by EMS agencies. And what are some of those basic standards under which they would operate. Here's a little video. Now, remember that when you go on to mybrady.com, all of this information that we are going to look at in the PowerPoints is available. All these multimedia things are available as individual videos, so you can always go back and review them if you'd like to.
In 1869, the Bellevue Hospital Medical College introduced the first ambulance service in the United States. The service was established to transport civilians to the hospital. Interns rode in these ambulances, doing whatever they could to comfort the patients. By the 1890s, this idea spread to other large city medical schools and hospitals. Yet by 1950, many small towns and rural areas still had no ambulance services, some offering little more than transport by the local funeral home. Over the next 20 years, however, great strides in ambulance transportation took place. Most significantly, the extension of the hospital emergency room, or department, to the patient through the Emergency Medical Services (EMS) system. With this advancement, care could begin at the scene, continue during transport, and then be handed off to the staff in the hospital. By 1966, the National Highway Safety Act was passed, granting the responsibility for developing standards for training, assessment, and care to the Department of Transportation, DOT. This standardized EMTB training, assessment, and care. A fully standardized First Responder National Program was presented in 1994. Often, it seems that EMS response is a given, but its development and spread has taken well over 100 years.
All right, there were some pretty old vehicles, and those uniforms were pretty dated there, weren't they? That aside, think even since this video was made, probably, I don't know, maybe late 1980s, think about what we've done today. Nowadays, I can take an EKG on my monitor and wirelessly transmit that to the hospital. The doctor can look at that EKG, interpret it, determine if the patient's having an active heart attack, and by the time we arrive at the hospital, the cardiac cath team is ready to go, ready to receive that patient. It is not uncommon at all from the time of a 911 call being placed to the time that a patient is on the cath table undergoing a surgical operation to be within 60 to 90 minutes. That's incredible. From placing the 911 call to being on an operating table in 60 to 90 minutes is just unheard of. And a lot of that comes from the development of technology. Every ambulance today has internet access readily available. So here's the NHTSA again, National Highway Traffic Safety Administration. If you remember, that's a department within the Department of Transportation itself, okay? And they have a handful of responsibilities that they've been charged with. I'm not going to go through and read everything to you. You guys are capable of doing so, and this is also covered in your textbook. But all of us are learning today the curriculum under a national standards, a national scope of practice model that provides us guidance throughout the entire country as far as how we should be training EMTs. What is the core content? What are the core skills that they should be learning? Resource management will help us to centralize or standardize rather how ambulances work, the types of equipment that's going to be on them, how they need to be outfitted. You guys may not realize, but when you see that chevron striping, that kind of diagonal striping on the back of an ambulance, that's standardized. That's required by law. The type of lighting, emergency lighting, the height that it has to be, the colors that it has to be, where it has to be located on the ambulances. All of these things are standardized and required through either a state law through Illinois or at the federal level. Talks a lot about human resource management. What are the training requirements, both upfront and ongoing. A little bit more in the way of transportation with the ambulances. Governs even facilities and goes as far as governing basic things at fire stations and also at the hospitals themselves. Communications has evolved substantially. Imagine the leaps and bounds that NHTSA has had to cover to keep up with the evolvement of technology. Nowadays we have things like you dial 911 and your GPS location can pop up on a map, accurate within just a few yards. There's even new applications these days through the American Heart Association where somebody can hit an alert on their phone saying that they need help with CPR, and it will alert CPR trained individuals within a certain geographic area of this need for help, allowing them to respond somewhere. Let's say that you're in the mall and this app pops up that somebody on the other side of the mall is in cardiac arrest. It gives the trained individuals the opportunity to get there and render that level of care prior to an ambulance arriving. Public information and education, I think, goes without saying. The more education that we can provide to the public, the more that we can prevent from happening in the first place, the better off we are. We focus a lot on getting to the scene and responding to emergencies, but it's just as much our responsibility to educate the public to try to prevent those emergencies. And it may even be, simple things such as doing basic safety inspections of an elderly person's home, looking for loose rugs that they could trip on, things like fire hazards such as extension cord use. But it can also extend out to CPR programs, AED use in public locations, those types of things. Covers medical direction. We'll talk a little bit more about that in this chapter, but remember, the medical direction is the ability for somebody to actually provide us with direction on what we should do. And that may be either through a written format, such as our protocol book, which would be considered a form of offline medical direction, or they could tell us directly over the phone, here's what I want you to do. I want you to administer this medication at this dose. And that's an instance of online medical direction then. Covers our trauma systems, different level 1, level 2, those types of things. And then also we have to be able to evaluate our performance. How is it that we are performing? Are we doing well? Are we seeing improved patient outcomes? So that QA or QI is really, really important, and that's something that's very heavy, especially within our EMS system here. All right, ready for a pop quiz? Here we go. What Illinois state agency oversees EMS and issues licenses to practice within the state? Now, you may remember this from First Responder if you took that course, but the Illinois Department of Public Health actually governs all of the stuff within the state here. And throughout this class, you'll learn a lot about IDPH and the fact that you're actually going to be operating under an expanded scope. The Illinois EMTs, paramedics, we have the ability to render slightly more care than what the national standards require. So that's kind of unique. But ultimately, that's all set by the Illinois Department of Public Health. And IDPH will issue our license. So at the end of the class, you will take a state exam. If you pass that state exam, you will apply to the Illinois Department of Public Health for your license to practice within the state. All right, components of the EMS system. So emergency medical dispatchers, or EMDs, are oftentimes discounted. Throughout the class, especially if you have me as an instructor, we'll spend some time listening to different dispatch audio and whatnot. But it's really amazing what these EMDs can do. I would almost argue that their jobs may be harder than ours. At least when we get on scene, we have all of our senses. We can see, we can touch, we can smell, we can hear. All these things that we can do to help determine what our treatment plan should be. But for a dispatcher, all they have are the eyes of the frantic 911 caller on the other end of the line. They have to rely on somebody else's senses and be able to communicate with them, draw accurate information out, and in return be able to provide them with important instructions on how to render basic levels of care until an ambulance can arrive. If you know any dispatchers, be sure to really thank them for the services that they provide. They are very much so underappreciated. We then have our EMS responders, EMTs, paramedics. We have pre-hospital RNs, field doctors in some instances. So there's varying levels of responders that can fall within that. And then we have our actual emergency departments. You'll notice that it's emergency department, not emergency room anymore. The official vernacular is actually ED, no longer ER. And that's comprised of a multitude of different resources, doctors, nurses. When we see allied health personnel, that can include things from a respiratory therapist all the way through somebody who comes in as a specialist for whatever type of injury or illness they may have. And then we also have our specialty centers that can deal with additional issues. So some of the specialized trauma care that we have within our area would include Lutheran General Hospital in Park Ridge, Rockford Memorial in Rockford, and Of note, Rockford Memorial now has two different facilities. They've since this PowerPoint was made, they've been bought out by Mercy Health. They have the Rockton campus, and they also have a new campus on Riverside at the intersection of Interstate 90. That's a brand new hospital, just opened up in the fall of 2018. Beautiful trauma, level 1 trauma center. St. Anthony's in Rockford also has a trauma center, so ultimately Rockford is full of trauma centers, and if you know anything about Rockford, you'd understand that they need all those trauma centers. We also have Condell, which is in Libertyville. That's not on this list. And Condell is probably the hospital that is now most frequently transported to. Burn centers, St. Anthony's in Rockford has a very, very small, I don't want to call it a part-time burn center, but it's not as comprehensive. It'll take care of basic illnesses related to burns or skin-related diseases. Loyola, though, down in Chicago, has a very, very comprehensive burn center. And I'll tell you, during the time that I took paramedic class, I had an opportunity to go down there and do clinical time. What an experience. I remember, there was a gentleman there that was a utility worker, and he was working one of those underground vaults, utility vaults, and there was an explosion down there. And he was completely wrapped, almost looked mummified. He had been there for, I think it was approaching 6 months at the time I did my clinical time. And he was still heavily sedated, still intubated. And the only areas of his body that were not burned was the area protected by his underwear and also by his boots. Everything else, the single layer of clothing on his pants, his shirt, and obviously anywhere that was not covered by any level of clothing, was second and third degree burns. And the amount of work that went into caring for that individual each and every day, it was without a doubt one of the most sobering experiences I've ever had in my entire life. And I hope that educational opportunities like that at the burn centers continue to be afforded to the paramedic students. Pediatric centers, so Loyola again down in Chicago. Rockford Memorial has a pediatric unit. And then the Robert H. Lurie Children's Hospital in Chicago is probably one of the most world-renowned children's hospitals. They also have a physician, a pediatric specialist, that works out at the Northwestern Huntley facility. So while Northwestern Huntley is not an official pediatric center by any means, they do have some resources there that better equip them to deal with pediatric emergencies, more so than the other hospitals throughout McHenry County. Again, this is a slightly outdated PowerPoint, but not only is Centegra now Northwestern Medicine, but we have cardiac centers available at both the Huntley and the McHenry facilities. So both of those are appropriate centers to transport anybody having an active heart attack. Stroke centers, just about any hospital is going to be designated some level of stroke center capable of administering or receiving a CT scan right away. So Northwestern, Woodstock, McHenry, and Huntley, all three have the abilities for a CT and are designated as stroke centers. In addition to that, you've got Good Shepherd and Barrington. So moving on then. Looking at the bottom there, what are the possible consequences of transporting a patient to a facility not equipped to handle the problem? Think about that. If you are 10 minutes away from, let's say, Northwestern Woodstock, and you are 15 minutes away from Northwestern and McHenry, common sense may say, hey, I should go to the closest hospital 10 minutes away instead of 15. The downside is, what if that patient's having a heart attack? If you transport that heart attack patient to Northwestern Woodstock, only 10 minutes away, you've actually done them a disservice. Being able to get patients to hospitals that are equipped to provide them with the care that they need is it is our number one priority. So even by driving 15 minutes instead of 10, but getting them over to Northwestern McHenry, they have a full cardiac cath suite there where they can render the emergency care that is needed for that patient, thereby improving the patient outcome. So just a visual kind of related to all of the stuff we've been talking about so far. You'll see it starts with the point of injury or illness, the 911 call, moves on to the EMDs, ultimately to the EMTs and paramedics arriving on scene, and then down to rehab and recovery afterward. So accessing the EMS system, 911, I'm not going to spend a whole lot of time on this, but one thing you do want to know is that with E911 or the enhanced 911, that provides the dispatchers with a slew of additional information. If I were to call 911 from a basic, let's say a payphone, most of you probably don't even know what a payphone is, but if I were to do that, it wouldn't provide much in the way of information about the source of the call. Whereas if I call from a landline registered to a specific home, or even from a cell phone, they can start gathering information as far as who owns the phone, who's registered, who's registered on the account, what is the location of the call, those types of things. EMDs, I think we've kind of hit that enough. Remember though that they are provided, they are trained as EMS providers. They can provide instructions on CPR directly over the phone. I actually have a dispatch recording of a dispatcher providing aid to a father to deliver his own child in the living room. And that's something that I'll play for a later presentation. But they can do a whole slew of things that really help to provide some level of care prior to EMS arrival. So critical decision making is a very important concept in EMS, and that is certainly the truth. You will be posed with making decisions all the time. And although you're provided with a protocol book, and we're going to spend a lot of time going over protocols, and if this happens, then do this. Unfortunately, no patient ever presents exactly what we see in a protocol book. No patient will ever present exactly what you see in your textbook. You're going to have to think critically. You're going to have to blend multiple protocols together to render the appropriate level of care. And you'll understand throughout the class, our standards are very, very high. Our expectations of you are very, very high. And the reason being because not only are you a potential risk to your patient if you don't know your information, but you're a potential risk to yourself also in the form of liability. So we will expect a lot out of you, but we will also provide you with the tools and resources necessary to make sure that you are successful. So here's some critical decisions that you may have to make. Is it better to take a patient to the closest hospital or to one farther away but more appropriate for the condition? We just talked about that. The answer is yes. Is the patient stable enough for further evaluation on scene, or should the patient be transported immediately? Scene time is one of the most important things that you can try to control. There are some EMS providers that feel that they should stay on scene for 15, 20, 25 minutes, trying to render all this care and perform these in-depth comprehensive assessments. At the end of the day, our job is to get the patient to the hospital, and more importantly, to the correct hospital. And we need to become proficient in doing assessments, rendering care while in the back of a moving ambulance. We need to be able to minimize the amount of time it takes from the point of injury or illness to the time that they get to that definitive level of care at the hospital itself. So manage your scene time. That's something you'll hear us talk about a lot. Will this treatment make the patient better or worse? Well, that's a good question. Sometimes a protocol will tell us to do something, but if we've done a good proper assessment, we'll realize, hey, maybe this isn't the appropriate course of treatment. Maybe this is going to take too long. And in those situations, we should be contacting online medical control and running our thoughts by them. Ooh, okay, levels of EMS training. This is colorful. There's a big, bright yellow call out with an exclamation. Again, probably should clue you into the fact that this is going to be something you'll see again. So depending on if you are taking EMT again to try to refresh yourself after being licensed years ago, or even if you have an older sibling, a mother, father, whoever that's on the job, they may still be using old terminology. And you'll see this is what we use today. So what we've previously called first responder is now an emergency medical responder. What we previously called an EMT basic is now just simply emergency medical technician or EMT. An advanced EMT Used to be called EMT Intermediate. Again, that's gone by the wayside. It's now AEMT. And then what we used to call EMT paramedics is just simply paramedics. The need for the change, who knows? Whether or not it simplified things, who knows? But nonetheless, the terms that you see in color, that's what we're using today. So personal safety, priority number one. And throughout the class, we're going to talk a lot about prioritizing personal safety and how that is different from risk taking. There are times that we're going to need to take risks, and there are times that we're going to have to operate in a area that is not entirely secure or safe. At the end of the day, what we need to do is risk a lot to save a lot, risk a little to save a little. And we're going to do so through calculated risks. We need to determine exactly what is the benefit of me taking this additional risk. If I can risk a little additional and I have the potential to save a life or more than one life, I'm probably going to make that call. So we'll talk again throughout the semester about really how we need to prioritize that. Beyond that, then, we have the safety of our crew, the patient, and our bystanders. From there, we move on down through patient assessment, care, and transport to the hospital. But again, remember, your personal safety should be priority number one, and then that of your crew and your patient and others surrounding you. How would it impact an older adult patient if they were transported to the hospital without glasses, hearing aid, or dentures? This is something that's really important, and as a new EMS provider, you're going to be nervous on your first handful of calls. You're going to be very focused on treating your patient, and sometimes we forget the simple things that are just as important. Case in point, I had a patient one time who was having a stroke. It was an obvious stroke, and time is of the essence there. So we identified the stroke right away, threw the patient on the cot, got him in the back of the ambulance, drove to the hospital, had only a scene time of a couple minutes. Overall, I was pretty impressed with the level of care that we provided. Later that afternoon, we received a civilian complaint. Received a complaint from the family of that patient, whom we arguably saved, right? Got him to the hospital and allowed them to have a positive outcome. But when we put him on the cot, we didn't cover them with a blanket. And it was wintertime, it was cold. And the distance from the house to the ambulance was maybe 30 or 40 feet. And we didn't cover them with a blanket. And at the time, I was pretty upset, thinking, that's really petty. You've got to be kidding me here. That, here we are. We did a great job. We minimized scene time. We got this person to the hospital and gave them the best chances of a positive outcome possible. And you're gonna rag on us, not to mention file a formal complaint because we didn't cover them with a blanket. And after I got over myself there and realized, what, yeah, I guess that's important. Because to that family member, even though they're having a stroke, and we as EMS providers understand the significance of that, family always wants to make sure that their loved ones are cared for, that they're comfortable, and that we treat them as we would one of our own family members. So simple things like making sure that they are bundled up and covered with a blanket, making sure that we shield them from the rain, making sure that we transport them with things like glasses and hearing aids and other comfort items is really important. So we shouldn't discredit that. Just because it's not a life-saving technique or life-saving skill doesn't mean that we should ignore it or not value that. So I'm going to skip through some of these other things. Again, you can go back and read through them if you'd like. Physical traits of a good EMT. I'll tell you what, this is this is a tough one here. And I don't technically agree with all of these things on here. Yes, we need to be able to lift and carry equipment. Yes, we need to be able to lift patients up to 125 pounds. But I'll tell you, I don't deal with very many patients that are 125 pounds. Most of our patients are much, much heavier. And unfortunately, a lot of the back injuries, shoulder injuries, things like that come from lifting heavy patients. More so than just being physically strong, you need to be mentally smart. You need to identify that I don't care if you're a muscle-wielding championship weightlifter. You need to be able to identify when you're unable to safely move a patient, lift them, etc., and know when to ask for help. All of my new EMTs, I don't care how strong you are. I don't care if you go into the gym and show off. All I care about is that you're smart enough to identify a situation that you may not be properly equipped to handle. And when that happens, stop and ask for help. Because ultimately, when you hurt yourself, there's a good chance you're also going to hurt your patient. You going out on injury doesn't help anybody in the future, nor does your inability to help that patient at the time. So stop and ask for help. Good eyesight, distance, and reading. There's going to be minimum. You're going to have to do a physical whenever you go to apply for a job, and they're going to do things like eyesight and stuff like that. Don't think that if you have anything less than 20/20 vision that you're not going to get the job. Things that are correctable, and as long as you can read your protocol book and see your patient effectively and drive safely in an ambulance, you're probably going to be all right. Awareness of any problems with color or vision. Again, I have what would be considered a color deficiency. I don't want to say color blindness. I don't see black and white necessarily. I do see colors, but different shades are tough, to the point that I have to show any outfit that I'm going to put on, especially a suit. I have to show it to my wife and make sure that I've got matching coat and pants and stuff like that. So, and I still tend to treat my patients just fine. Good communication skills, though. This one I will certainly speak on. Many of the students that are coming through the classes these days have very poor communication skills, and you may not realize it even. Unfortunately, the day and age of text messaging and instant messaging and all this other type of messaging has really impacted our ability for interpersonal communication, our ability to interact with others face to face. And you're going to be posed with the requirement to ask some really, really odd and personal questions. You know, if you have a hard time smiling and saying hello to somebody, to a perfect stranger, as you pass them in the hallway, how are you ever going to walk up to somebody and ask them to describe their last bowel movement to you? Or if you're a male provider, go up to a female patient and ask her to talk about her last menstrual cycle. These are all things that, you know, as EMS professionals, we're going to be poised with the responsibility to ask these personal questions. And we need to be able to be confident in our communication. Beyond that, things like eyesight is really important. If I'm simply looking down at the ground while talking to you, how confident do you feel in my recommendations as far as EMS treatment and stuff like that? As compared to if I look you straight in the eye and it shows that I'm being earnest, that I'm confident in what I'm saying to you. These are all really important things when it comes to communication. The written component, you have spell check, use it. There is absolutely no excuse to submit a patient care report or other report with misspellings on it. There's a wealth of resources available to you. Every one of you, I guarantee, has a phone in their pocket capable of Googling something. If you don't know how to spell it, Google it. If you're not good at spelling or writing, use spell check and have somebody proofread it for you. Because remember that your patient care report, you may be sitting on the witness stand in court one day with a copy of your report projected up on the screen next to you. And how professional will you look when all of those words are misspelled? So use the resources available to you. There you go. I read and write real good. It's okay if you're not good at it. It's not okay if you don't take the time to use the resources available. So some other stuff: pleasant, sincere, cooperative, and resourceful. I think that's really kind of common sense. Resourceful is probably one of the big ones on here. You know, what happens when something doesn't work right? What happens when the tool or equipment that you're using, or somebody even forgot to restock some supplies? What happens then? How are you going to respond to that? Are you just going to get flustered and say, now I can't do it? Or are you going to find a different way to make it work? So there you go. There's a professional looking individual, right? A sweet haircut, awesome glasses, got gloves on. If you don't look exactly like this guy, that's fine. But keep in mind, professionalism is really important. Self-starter. That means showing initiative. If I have to ask you to get vital signs in the back of my ambulance, you're not doing your job. You should know what needs to be done. And we should be, as a team, we should be able to work together without saying a whole lot to each other. The bulk of our communication should be focused on communicating with our patient and not among each other. So keep that in mind. Emotionally stable. Now that's a tough one. Yes, you need to be emotionally stable to the point that, in the heat of the moment, under these high stress environments, we need to continue to perform, and we can't allow the stress to overcome us when we're dealing with our patients. However, you will see things, you will hear things, you will experience things that is some of the worst that life has to offer you. If you're not stressed, if you're not saddened, then there's probably something wrong with you. We're all going to be stressed. We're all going to feel this wealth of emotion overcome us. And throughout the years, this job will become more and more of a burden on your everyday life. So it's important that we realize that and that we treat our stresses and our emotions appropriately. We need to take the time to talk to people, to feel comfortable communicating with our coworkers. Hey, I really had a hard time with this call. I need to go talk to somebody about it. And those resources are available. That doesn't make you weak. That doesn't make you unstable. That just simply makes you a human. So please never bottle up your emotions inside. Always have a resource, always have an outlet to talk to people. All right. Emotionally stable does not mean that you're a vault and that you don't share that information with anybody else. Able to lead, those leadership traits, some of you have them naturally, others you'll have to work at that. And that's something that will develop with time. Neat and clean, I think, speaks for itself, of good moral character and respectful of others. That's huge. In control of personal habits. Do you bite your nails when you're nervous? Do you have some type of nervous twitch? And if so, if you're in the middle of talking to a patient, or even worse yet, talking to a family member while we're working a full arrest on their spouse or their loved one, if you're standing there biting your nails, is that going to convey a very professional, confident level of service? And the answer is no. So we need to be aware of those things and we need to be able to control them. Again, communication pops up there. You'll see able to listen to others. Ooh, that's a good one. How many times when engaged in conversation are you thinking about your response before the person even finishes talking to you? You need to stop. You need to listen. You need to hear everything that somebody says to you. You need to process it, and then you need to formulate an appropriate response. So able to listen is really important. And especially for our patients, if they don't feel that we're listening to them, it doesn't matter if we're the best EMT or paramedic in the world. They need to know that we're there, that we're listening, and that we care about what's wrong with them, and we're going to provide them with a great level of care. Non-judgmental and fair. As far as non-judgmental, you're going to see some pretty interesting things, and it's going to be hard not to judge, but that's not our job. We just need to take care of our patients. Simple as that. Education, if you don't love school, you might as well go ahead and drop the class now. You will be in school for the remainder of your careers. EMS is always evolving, always changing, and there are updates, new courses that we need to take. We need to go to conferences and seminars. We need to read publications, journals, magazines, etc. We will always be involved in education the rest of our career. So how will you refresh your knowledge and stay current once you are out of the classroom? Don't you worry, any EMS system that you're affiliated with will provide you with plenty of ongoing continuing education. Lots of different places you can become an EMS provider. Private ambulance companies, fire departments. You can be, if you go out west on the wilderness teams, they again, similar to military applications, have frontline EMS professionals that can render care out in the fields themselves. You can also volunteer in some circumstances. There's a lot of you see the Tough Mudder events and other outside events. A lot of those companies actually hire EMS professionals to work first aid for them also. Great America. You can go get a summer job at Great America as an EMT or paramedic. They actually pay pretty well too. And you get to drive around on a sweet golf cart. All right, so moving on then. There you go. There's Great America, Six Flags, right? Wouldn't it be cool to work the summer at a water park, work on your tan while also providing care for others? National Registry. So they allow all different levels of EMS providers to register through them. They provide additional content, education, resources. But in addition to that, if you are registered or certified through the National Registry of Emergency Medical Technicians, then there's a lot of states that will take that certificate, and you can apply that certificate to the specific public health department for the state and receive a license to actually render care. And just to explain something there, in each and every state, you have to have a license to actually work and provide any level of EMS care. Simply having a certificate means nothing. So if you have your certificate through NREMT here, that does not authorize you to touch a single patient in any single state within the US. What that allows you to do is take that certificate to that state. The state will evaluate it, determine whether or not you've met their core requirements, and from there they may either accept that certificate and issue you a license. They may require you to take a test, or they may require you to take a course. And at that point, once you receive an actual license, then that license allows you to practice in that state. Quality improvement, we've talked about that. We need to review everything we do, everything from our patient care to the reports and everything in between. All right, medical direction. So there's an important distinguishment between a medical direction and the medical director. The medical director is a single individual in our EMS system. That's Dr. Piccini. And he helps to do a handful of things, including establish the protocols. He has the ultimate responsibility for patient care throughout the entire system. So if any of us screw up, not only are we going to be held responsible, but he's also going to be held responsible. So he takes on quite a bit of risk and liability in his role. As such, he has high expectations for us, and he expects us to meet certain benchmarks, maintain certain levels of education, ongoing training requirements, etc. The big thing, though, is Dr. Piccini, along with several other Region 9 physicians and consultants, they work to develop the protocols that you will be operating underneath. So when you follow a protocol, you are following Dr. Piccini's explicit directions. Here's what I expect you to do in this certain situation. Now, Dr. Piccini, being a single individual, is not available for phone calls 24/7, 365. He's a human just like the rest of us. He needs his time off. So he can delegate his authority to other emergency room physicians in his absence. So we can still call the hospital and we can talk to any ECRN, emergency communications radio nurse. We can talk to any ED physician, and they will be operating under the same protocols set forth here. They'll be operating under those protocols, and they will provide us with any level of care. Any level of instruction. So when they tell us to do something, that's an issue of online medical direction. They say, listen, Scott, I want you to administer Narcan at 0.4 milligrams through the intranasal route. That is online medical direction because they are telling me specifically to do something. Whereas if I were to read it in the protocol book, that would be an example of offline medical direction. EMS role in public health, prevention. We kind of talked about this a little bit earlier. Prevention, doing basic inspections, and we should be doing this every time we walk into somebody's home. If we see a potential risk, we should acknowledge it, and we should offer a solution to try to fix it. Maybe that's reporting back to our Fire Prevention Bureau or our Public Safety Bureau. Maybe it's something as simple as, hey, this rug is loose. Can I move this somewhere else for you where it's not a trip hazard? We should always be on the lookout, providing that preventative level of service in addition to the responses that we would normally be doing. So you're all a public servant. What does that mean? What does it mean to be a public servant? And it's in the title. We serve the public. We do whatever we're needed to do, whenever, wherever. We don't show up and say, "Oh, sorry, that's not something I'm willing to do." If somebody has, if somebody is disabled and they have experienced, they've had a bowel movement and they need help getting up and cleaning up, then we do it. You'll see on Facebook all the time that a fire department will respond for a medical call, somebody having a heart attack while mowing the grass, and while the ambulance transports over to the hospital, then the fire crew stops and actually helps finish mowing the lawn. Just different acts of public service like that. All right, research. Um, you'll see this again in the past. Now, this is important. In the past, what we did was based on maybe the medical director's experiences, best practices, utilized in the emergency department. But today, what we use is actually, if it's called evidence-based processes. So based on scientific studies, research, analysis, etc., that's what shapes our protocols. That's what shapes our procedures and our skills. It's not based on any one person's opinion or experience. This is really scientifically based. And that's really important because now we can actually start to back up a lot of the things that we do, and there's science behind it to prove, yes, this is the best way of doing things. Um, for people who have been EMS providers for any amount of time, 10, 15 years, they've seen CPR change substantially. CPR changes how we do it, the rate, the ratios, a bunch of other stuff. It changes every few years. And I often joke it's because the American Heart Association wants to sell new books, but that's really not the truth. The truth is, we have a wealth of information through studies and research available to us now. And through analyzing it, we now realize there are better ways that we can be doing CPR. By tweaking little things, we can improve our patient outcomes. So research in EMS is one of the most important components that we have available to us these days. So I'll let you read through the rest of this stuff. I can promise you, you're not going to see it on an exam or a quiz. And quite frankly, it's not even something that I'm going to take the time to talk about right now because you're already probably starting to nod off at your computers. So research is important, but I don't think we need to go through and hit on all of this stuff. It's just a little too in-depth. All right. Chapter review then. So we talked about the origins of EMS, dating all the way back to the Napoleonic Wars, and the evolution throughout time. We talked about how military applications of EMS is really what built and shaped civilian EMS here in the United States. We talked about communication and the EMS system, starting with the point of injury or illness, moving on to the 911 caller, the emergency medical dispatcher, and ultimately all the way up through allied health personnel. And we talked about responsibilities, safety being one of the most important, but also our responsibility to ultimately be a good person, to remain engaged, remain educated, etc. And then all the other components of each individual call, such as patient assessment, transport, and transfer of care. All right, I think we hit on that stuff. Sounds good. If you guys have any questions on anything, feel free to email your instructor or bring them up in class, and we'd be happy to answer them for you. In the meantime, see you on Chapter 2. Thanks a lot for listening.